Hey guys, Don here. Welcome to Podiatry Practice Mastery. Going to go over the $1 Million Minute. These are the things that help me get my practice to the $1 Million mark and beyond. So I'm recording this. This will be of a Friday. And before I begin, I just wanted to say I was at a recent shockwave conference, and there were a few members of my Practice Mastery Academy there. And some people. I was talking to Jeremy specifically, and we were talking about staff issues and how to keep new doctors producing or as motivated as some of the more senior doctors. This is something that we find a lot is the doctors that are owners, they tend to work harder, produce a lot more, and the other ones, they're either just want to be salaried or they're not too motivated. They're motivated to do surgery, right? That's kind of where our residences are going, but not much to produce profits or learn what's kind of profitable. But I'm hoping that this will change things with this podcast. That's what I'm trying to do. Is the kind of showing how to get to the $1 million mark. So surgery can be part of it, but it's not a big part of it. And the other thing he said, Don, how are you able to do everything? And sometimes it can be a little overwhelming because as you're hearing me here, I'm in the clinic most days. When I want to tell you my process of recording this. So what I do is I tend to leave about a 10-minute buffer when I go to the office in the morning. And I have a printout every single day of the patients that I see. And on this printout, I write out what I do for these patients. And I think it's good for me to keep my eye on the prize. I tend to give preference to what my most valuable patients are. And it's good for me also to talk through this for you because it's able just to kind of keep it front and center of mind. And hopefully it'll help you to produce more and kind of teaching you the way I can do that. Now, I don't think I could write on this paper if I didn't have a scribe. I think the first thing is if you want to produce more, you have to be freed up, and I think my scribe frees me up a lot, meaning Morali does all of my notes, and so all I have to do is go in and check his notes, make a few modifications, and I can write it on the sheet. If I was trying to see this many patients and doing my notes, even with the templates that we have, I think it would be really hard. So I think a lot of it is being freed up with medical assistants and scribes and nail technicians and things like that. I think you get to a point where you just want to pay to get your time back. And the next thing I'm looking to buy or to get my time back is to get a practice representative. I think that's going to really take our practice to the next level. I'm still kind of working through that. I haven't quite figured it out, but I'm working on it. Okay, so this is a day, like I said, there were 35 patients. I'm doing routine care. I'm not going to go through. So the way the routine works, from 8 until 11:30, I'm seeing routine every 10 minutes. My nail tech, has her own schedule, so she's seeing they're all kind of bunched together. She's going in, just seeing them, and then I'm kind of catching up. And you'll see that some of these are kind of complex things, and so that kind of gets me behind, and then I catch up with her, and that's kind of how it works. Okay. So I'm going to go through the things that are like office visits. So patient, 85-year-old patient. Actually, that was just a nail care. The other one was a patient that had. He actually was an 85-year-old. I was looking, did I really give an 85-year-old terbinafine? And I did. Let me explain why. So he had nail fungus, but I'm not doing it for that. He had quite bad athlete's foot, maceration between the toes, and he couldn't get down to his feet. And so because of that, I put him on a month course of terbinafine for his athlete's foot. That's why I did it. Okay. Next patient was the 79-year-old patient. That was an ulcer. I debrided it and kind of planned. I talked to a podorthist on the phone during the course of the treatment, and I also emailed the wound care center. So she's being seen by the wound care center. I think she needs a total contact cast, and then she needs to get in a custom diabetic shoe. So these are the things that I kind of did in that counter, and then my scribe documented that thing in the encounter. Next patient was a 64-year-old with a fissure, and we did my fissure treatment. So what is my fissure treatment? The fissure treatment is in the morning. It's a Cara 42, like a 42% urea. They put on their shoes with a heel cup, just one of those plastic heel cups that doesn't chafe, and then at night they put on the sleep and heal socks. I find that tends to work along with trimming down the callus for these patients. Sometimes we put super glue on them as well. Next patient was a 58-year-old for a diabetic foot exam and nail care. And next patient was a patient I've been seeing for a long time for bilateral calluses on the fifth med head. She's a self-pay patient. She owns a lot of horses, and she likes to ride. And those calluses bother her. Now, those calluses, 2 of them on the fifth med head that are hurting her the most are IPKs. And because of that, today I offered to numb them up and remove them. So numbing them with a 1-to-1 mixture of 1%, lighted with epi, and then another 1% lidocaine. So 1-to-1 mixture, 3 cc's, put our cc.5 under each. I used a punch biopsy to remove that, and that's kind of what we did for that patient. Okay. And then I'm not going to see her back for this. I'm going to just see her back as needed. So self-pay, it was just the regular 75 for the callus care. Each of the excisions, I think they were like 160 times 2. And then I did not send it to pathology just because she was self-pay. So that's kind of how, in terms of the billing, all of my kind of self-pay fee schedule things, they're all within the Practice Mastery Academy under the medical EMR stuff, the medical records and forms and everything else that we use in the office. Next idea that I had, actually she got some gel met pads too. So she got those to kind of offload that area. The other idea I had, I was talking to one of the patients, and this patient said, hey, the physical therapists that you refer to, they have a newsletter as well, just like yours. They do theirs quarterly, and we do ours weekly. But I was offering to him to do kind of some cross-promotion, like putting an ad or an article that he would write in ours, and then we could put one in the one that we write into theirs. So kind of as a way to cross-promote the patient lists. Next patient was a patient that had a bursa on the fifth metatarsal base region, kind of at the styloid process. This patient, I did an ultrasound, and it was painful, and I did a cortisone injection on that area. And I also talked that if it didn't calm down, we might do a shockwave. I had a similar patient with one on the fifth med head that responded well to an amnio injection and shockwave. So let's see how this cortisone works, but if it doesn't, that would be the next step, and I kind of prepped him for that. Next patient was a 72-year-old patient, diabetic foot exam and nail care. For the foot exam, he did have some venous stasis changes with some small ulcers that were scabbed, and so I used the venous stasis for the diabetic foot exam, and I just did the nail care. So if you looked at a recent article, usually when you're doing an E&M, you need to have a diagnosis that you're talking about, that you're discussing, that you're giving treatment recommendations for, versus just using diabetes. Another patient that was here, this was a patient that came in on a stretcher, and they had needed nail care, and then they had an excoriation on one of the toes, so that was an office visit, talked about it, was not infected. That's why the wife brought him in on a stretcher. And then this is a patient that I gave to Marjorie. Basically, I gave Marjorie her phone number to them. And in the future, instead of getting a van and an ambulance to bring them in for nail care, I just said that Margie would go to their house to do that. And she is a nail technician, so she does kind of home care visits. She's the one that helps us here. She will not do like calluses, but she'll just do the nails for them. I had a patient today, that only one out of all these, that wouldn't see the nail tech. So we also ask patients if they're willing to see the nail tech. If they're not willing, we don't make them. Okay, so this patient wasn't willing. But he's kind of a long stand. He just likes talking to me, I think. It's not about her. It's more just he likes to chat. And then there was another patient. He was an 80-year-old. I'd like to know your opinion. This guy, he fell, and for some odd reason, he fell right on the distal phalanx of his hallux. And he had a comminuted fracture of the distal phalanx. The nail bed was intact. But he's like 80, and it was comminuted, and there's a big gap. He saw me after 3 months, and the thing was still kind of really swollen and bulbous at the tip. I'm just giving it time. I tried to have him in a surgical shoe if it doesn't affect his balance, but I wasn't planning on fixing that. Hopefully it'll just get better with time. So if you have any other ideas for that, please let me know. Okay, that was the morning. So the morning had a lot of nail care. Just so you know, the nail tech that we hired, she only works 4 half days. So she works the first half of the day with us, with the doctors, and doing nail care, and then the second half of the day she has her nail salon. So it's kind of a good gig for her because most people don't do nails before noon anyway. Now for the afternoon, these are normal patients. So first one was a 34-year-old patient that I'm going to be removing her tibial sesamoid, and it was the shockwave, pre-surgical shockwave. Number 2, she has one more on Monday, which is usually 72 hours prior to the surgery, to help with healing after post-surgery. Next patient was a 64-year-old. This is a patient that was on my trimbenophen regimen and the booster regimen, doing much better. I did a video just to put that on YouTube with that patient, just to show the results of that. I'm kind of telling you which patients I'm doing videos for. I try to do at least one video a day, and then I have a virtual assistant that uploads them as YouTube shorts. That's just kind of how I do it. Next patient was a 54-year-old that had shockwave number 6. He was here after having a failed exhaustectomy by an orthopedist, foot and ankle orthopedist to the posterior heel. Didn't really resolve his insertional Achilles tendonitis, so he's feeling much better by number 6, and we're going to see him back in 6 weeks, so there was an office visit for that one. Next patient was a new patient with bilateral nail fungus. I talked about we could take a sample and see them back in 3 weeks, or we just go right into it, and they opted just to go right into it with my kit, and so they did the kit. Next patient was a number 4 out of 6 for shockwaves for plantar fascial pain and Achilles pain, so I'm doing both locations. I'm not charging any more because it doesn't take me much longer to do. I do maybe 500 more pulses, and I just divide it between the 2 areas. So I would do, let's say, for I think it was unfocused today, I did 1,000 and 1,000 on each, and then for the radial, I would do 1,000 and 1,000, so 2,000 for each of those locations. Next patient was a 54-year-old with shockwave number 6. That was the one I just talked about, the number 6 one. Kit, number 4 out of 6. This patient's shockwave number 4, feeling much better. Going to do 2 more, so she's really pleased. Next one was a 36-year-old that we did shockwave number 1 out of 3. This was a new patient that was concerned about flat feet. So she really didn't have flat feet. On the contrary, she had kind of a cavus foot that was causing her to walk on the outside, on the left, outside of her foot. And she really had pain on her lateral inferior knee region at the pes anserinus region. And I found that that's very similar to like a tennis elbow, or very similar to like plantar fasciitis or Achilles tendonitis insertionally. So I find that shockwave works well. So I did the first of 3 sessions to that area. And when I documented kind of on the upper perineals. That's kind of how I document, because I don't want to go out of my scope, but because I do that whole area, including the perineals. And then she is going to be doing foam rolling on her IT band and her perineals as well. And I'm going to see her back to do another 2 sessions. She also got scanned for orthotics to help bring the ground up to her foot, so she's not overloading laterally, that I think was causing this. That was a new patient, 38-year-old. Next patient was a 59-year-old. She came in for a follow-up on her nail fungus, and I debrided just 1 nail, and I'm going to see her, no follow-up. She's doing much better after the booster, the Lamisil booster. Next patient was a bunion patient. This is a little girl. She was 17. So what happened is the first visit she had bunions and nail fungus, and my staff didn't get x-rays. So I just want to kind of explain this. If staff don't get x-rays on bunions, they should get x-rays for everyone. They had a question about it, but I didn't want to take the time that day. So what I tend to do is, I knew she was coming back in 3 weeks to go over the nail sample. So what I did is I put in 3 weeks and then x-rays at the next visit. So they came in, got the x-ray views. I reviewed the x-rays with them, so we have baseline. We're not going to be doing surgery, but at least we have baseline in case it gets bigger. And then I reviewed the nail sample. It was positive, but being 17, the mom said no oral medication. So I recommended Formula 7. The reason I recommend that one, I know some people really love Toselin. I think Toselin's a great product. I just have Formula 7. I don't hardly ever do anything topically, but I like it because it has a money-back guarantee. So I basically tell patients, when it doesn't work, then you can get your money back. I also recommended the biotin to help the nail grow faster. I recommended the UV light and the shoe spray. Next patient, this is a marathon patient that's trying to get ready for a marathon. He's having like 18 to 20 mile long runs on the weekend, and he has non-insertional Achilles tendonitis with thickening. He said he noticed big improvement after shockwave number 4 last week, and now it's number 5. And I think the reason from the recent conference I went to is it helps with the flexibility of the tissue after shockwave, like for 72 hours. So I did one now. I have one more next week. And his marathon's not for like a month and a half. And I recommended him even coming like a day or so before to do the shockwave because it does help with tissue flexibility and reduces pain. I think even in some things, I remember at the shockwave course they were saying that for horse races it's been illegal to do shockwave within like I don't know 24 to 48 hours prior because they consider it doping because it does such a good job at making the tissue feel better, being more flexible, taking away pain. And some people kind of in between, they do that. And then the final patient of the day was this little 13-year-old girl, and she had a wart, and we did Swift last month. I did a Swift today. They were much smaller. She tolerated them. I was at a level of 6, I think it's 2 seconds for 6 times, and she tolerated them today like a champ. I'm going to see them back on the 3rd visit, which all of those were scheduled, so she was pleased. So anyway, if you guys found this beneficial and you want kind of some help on your practice, I would fill out the practice audit. Tell me kind of what you're doing, what's working for you, and any struggles you have, and then we can meet on the phone to chat. I'd love to help you. That kind of gives me more fodder for this podcast as well. Okay, thanks guys.